Hello, my name is Sara Massee, and I was in the Pediatric Intensive Care Unit, or the PICU, at Marybridge Children's Hospital. The PICU is a 16-bed unit for critically ill pediatric patients with a variety of diagnoses requiring extensive physiologic monitoring, intravenous IV therapy, respiratory therapy, and nutritional support. So the PICU has critically ill patients with very complex needs. For the past 6 months, I have been working on a surgical site infection prevention pathway in the Pediatric Intensive Care Unit. This topic interested me because of the impact surgical site infections, or SSIs, can have on not only the hospital but the patients that develop these infections. According to the CDC, in 2015, there were an estimated 110,800 surgical site infections associated with inpatient surgeries, and costs for SSI were estimated to be $3.3 billion annually. So there is a high occurrence of these infections, and they are extremely costly. They are also associated with an increased morbidity and mortality. At Marybridge in the PICU, 2 patients who were discharged from the PICU developed SSI, and the infections led to readmission to the hospital. 2 SSIs after discharge from the PICU may seem small. However, discharges rarely occur from the PICU and are typically done from the medical surgical unit. So while this may seem small, this is actually very high for the pediatric intensive care unit. Also, readmissions related to the cases cause significant morbidity and harm to the patients. So in the PICU, there was really a need for improvement to try to reduce these infections and prevent harm to the patients. Currently, Marybridge has implemented an SSI bundle by partnering with Children's Hospital Solutions for Patient Safety. The bundle includes elements such as preoperative baths, perioperative and postoperative guidelines, and many other elements, but it has limited information on identifying high-risk patients for SSI after discharge. Literature suggests early detection of patients at risk for SSI can prevent SSIs and improve outcomes to reduce SSIs. Literature also suggests using care pathways to improve efficiency and effectiveness of care. I did a retrospective data analysis on past SSI cases and a comprehensive literature review of risk factors for SSI, and based upon that, created a pathway for nurses to use to identify risk of developing SSI. If you look at the SSI identification pathway on the screen, the nurse is taken through a series of questions to determine whether the patient is high risk. So, if the patient had a surgical site incision, they would be asked if they had cardiac, neurosurgery, or spinal fusion procedure, which are 3 very high-risk surgeries. If they answered yes to this question, they would continue through a series of 3 more questions. Was the patient diapered? Does the patient have comorbidities? Is the patient and/or family non-English speaking? If the nurse answers yes to one of these 3 questions, the patient is moderate risk. If the nurse answers yes to 2 of these 3 questions, the patient is high risk. If the nurse answers yes to 3 of these 3 questions, the patient is very high risk for SSI development after discharge. For the future, there needs to be associated interventions for the nurse to carry out based on these risk levels. These interventions are needed for the nurse to provide specific individualized care for the patients based on their risk level. SSI rates will be collected every 90 days and annually to determine if the pathway reduced SSI rates. The hope for the project is that there is a reduction in SSI rates after implementation of the pathway. There are a few things that surprised me about SSI prevention as I was implementing this quality improvement project. I was very surprised that there was nothing currently implemented at Marybridge to determine if a patient may be higher risk, since SSIs cause such a burden on the hospital and patients. I was also surprised how hard it was to narrow down the highest priority risk factors for surgical patients. It was a challenge to organize risk categories while also keeping it simple enough as well as efficient enough for nurses in identifying high-risk surgical patients for SSI. I know that SSIs are a huge problem for the hospital and that they contribute to high healthcare costs and increased length of stay for patients, as well as increased morbidity and mortality. These things were all reinforced by my research and retrospective data analysis. I think the biggest takeaways from this project is 1, SSIs can cause significant harm to patients and result in severe complications. And 2, With early detection and identification of at-risk patients, we may be able to prevent these infections. I would like to thank Marybridge Children's Hospital and all nursing leaders and others who have helped me in this quality improvement project. A special thanks goes to my preceptor, Tammy Bestbrandt, from the nursing manager from the PICU, for all of her amazing support and work with me on this project. Thank you.